introducing Dr. Fiona. Dr. Fiona D'Souza, she's a PhD and she's the head of scientific operations at Anderson Diagnostics Private Limited, Chennai. She did her PhD in clinical embryology and genetics from Manipal Institute of Higher Education, Manipal. And she is also certified in genetic testing and sequencing technologies from Harvard Medical School. She has over 15 years of experience. In her present role, she heads the genetic operations in Southeast Asia, India, Sri Lanka, Nepal. Primarily, she's heading the genetic counseling division also, and she has a deep role in developing the personalized diagnostic plan for patients with genetic disorders. Also, she is very well, keenly interested in social campaigns on developing awareness on genetic disorders. Her area of specialization is reproductive genomics, especially the pre-implantation genetic testing, PGT-A, PGT-SR, PGT-M, and NIPGT. Also, non-invasive embryonic quality assessment, endometrial receptivity, and rejuvenation. Now, these are key areas of specialization, and she is a real asset to Anderson as well as to Fertilis. An amazing person, always available to help, and we are very lucky to have her with us. Dr. Fiona has got over 13 publications in very high impact journals, and she's a very commonly invited faculty at national and international conferences. She's a member of IFS, SR, all the genetics groups she's heading in most of the Indian societies. And she's also a faculty with SRM, Institute of Science and Technology, Chennai, and a guest faculty at University of Colombo in Sri Lanka. So, Dr. Fiona, a few words for a great personality, and with this, I hand over the podium to you. Thank you so much. I'm stopping my screen, and you can take over. So,
Thank you so
I
much
think
for that warm introduction, sir.
You deserve much more, actually.
Okay, is my
So,
screen visible?
yeah, screen is visible. Make it full screen. Yeah, nice. So
Okay.
I invite Dr. Fiona to take the session on endometrial receptivity essay. Over to you, Dr. Fiona.
Okay. A very good evening, one and all. Today, I'm going to be discussing on optimizing implantation strategies, especially integrating embryo transfer with the endometrial receptivity evaluations. So when it comes to implantation, it is a complicated process. It involves multiple factors and both the interaction between the endometrium and the embryo. So the likelihood of a successful implantation after assisted reproduction is mainly determined by age, hormone levels, the endometrial status, the quality of the embryo, its cleavage speed, its developmental dynamics, ploidy status of the embryo, and also the male factors like genetic disorders, DNA fragmentation index, as well as external factors, which are the impact of the laboratory, the transfer techniques, etc. So if you look at the STRA consensus on how to evaluate implantation, it's usually said that with around 2 ETs, the possibility of a pregnancy and a successful implantation is at 47%. So as and when the number of ETs increase, the probability of a successful implantation increases. So it is usually said that you require at least 4 to 5 euploid transfers to achieve an implantation rate at 93%, which goes on to a pregnancy rate of almost 80%. Now, according to this, the threshold for recurrent implantation failure evaluation is at greater than 60%. If a woman is not pregnant after 3 ETs, then we plan to intervene. So there is a calculator developed by a Swedish group, which is available on ivfpredict.com. And they had evaluated the European data to come up with a consensus to assess the implantation potential of good quality embryos. So they divided it based on maternal age, and when ploidy was not considered, that means untested embryos were considered, below the age of 35, the implantation rate was around 31%. When it was 35 to 39, 25%, and greater than 40 was at 15%. So when you incorporate euploid embryos to this evaluation, the possibility of pregnancy, implantation as well as pregnancy rate doubles easily. So how the setup is done is that at the age of between 35 to 40, we tend to intervene after 2 euploid transfer failures, and above 40 also up to 2. But if it is not tested embryos, we tend to intervene after 3 to 4. interventions in the sense that we start incorporating other evaluations for the embryo as well as the endometrium. Why does RIF matter? Implantation failure is definitely a clinical challenge. It is multifactorial, and its successful implantation requires a precise synchrony between the endometrium and embryo, which means that multiple factors are incorporated. Now, if we look at the definition of RIF, there are several different types of definitions, but the practical working definition is RIF should be considered after repeated failed embryo transfers in IVF, and it should be interpreted in the context of female age, embryo developmental dynamics, embryo fluidity, rather than just a rigid embryo count tool. That means we don't just count it based on 1 ET, 2 ETs, 3 ETs. We have to factor in maternal age, the endocrine factors, fluidity factors, and then evaluate. So the failure following transfers of unselected embryos much of the time leads to false denotation of recurrent implantation failure. So what is the actual scientific biological explanation for recurrent implantation failure? It's a narrower perspective when you incorporate failure of euploid embryos to implant, which means that after the failure of 2 or 3 euploid embryo transfer failures, we then shift the attention towards the endometrium. Mainly we factor in then the receptivity, the immunological factors, and other etiologies for a rigorous evaluation. So if you look at the pathophysiology of implantation failure, it's mainly divided into the blastocyst competency. This is viability and developmental dynamics, the receptivity. Then you have the endometrial dialogue with the embryo. So the embryo should also have the right transcriptomic factors as well as the endometrium. We have to look at the luteal support and is the uterine environment normal in terms of anatomy, vascularity, and is there any obstructive pathology? So for embryonic components, the main investigation we apply is PGT-A, which is pre-implantation genetic testing for aneuploidies. For the endometrium, we look at the window of implantation, the possibility of infections in the endometrium, which is chronic endometritis, then the impact of progesterone and the endometrial response to progesterone. We also have to factor in structural challenges like polyps, fibroids, adhesions, etc. Endocrine factors that we have to rule out is thyroid, PCOS, obesity. You have immunological factors which include the antiphospholipid antibody syndrome, and you have NK cell activity. You have the DNA fragmentation from the male partner, which contributes further to implantation failure, as well as the aneuploidy from the male partner. Then you factor in also the lab-related factors. And then after all these factors have been ruled out, we still will have patients that fall under the unexplained category, where all these diagnoses turn out to be normal. Unfortunately, in these cases, we still don't have an answer. How do we go about it? Mainly, let me start with the endometrial factors. So the main cause of implantation failure is, of course, aneuploidy. 60% of implantation failures are contributed by aneuploidy. It is strongly age-dependent, especially maternally age-derived, which causes impaired developmental competence of the embryo. It may or may not affect its morphology. So aneuploidy is not related to the morphological grade of the embryo. However, the lab conditions that cause the embryo to be in a stress stage, which means that the embryo's oxidative stress levels are high, in that case also it can trigger an implantation failure. And the third factor is embryo mosaicism. Now, mosaicism is a phenomenon where the embryo has a mixture of normal and abnormal cells. And since we test the trophectoderm, the outermost layer of the embryo, this becomes relevant. Why is it relevant? Because the trophectoderm is the part of the embryo that interacts with the endometrium. So if the trophectoderm has a mixture of normal and abnormal cells, this can definitely impede implantation. This is evidenced by a multitude of studies. So, for example, I've kept an article here by VOT et al. Now, they evaluated 5,000 embryo transfers. They clearly saw that the implantation potential of euploid embryos was in the range of 57%. Other studies can go up to 70%. What they mainly focused on was the mosaicism. The mosaicism in the PGT report was divided into mosaic whole chromosome aneuploidies, mosaic without any selection, and mosaic that was blinded analysis. It was further subdivided into mosaicism at low level and high level. So the cutoff was 50%. Below 50% is low, above 50% is high. So when you compare the low level mosaic to high level mosaic, again, there is a minor difference in the implantation. the high-level mosaic embryos did fare a little lower. You have mosaic low-level 1 or 2 chromosomes. Now, if you compare the 1 or 2 chromosomes compared to the complex chromosomes, that is more than 2 chromosomes involved in the mosaicism, you always see that the implantation rate is lower. So as and when the number of chromosomes involved in the mosaicism increased, the implantation reduced. And as and when the mosaicism level also increased, when it went to high mosaic, the implantation potential was lower. So here, low mosaic 1% had an implantation potential of 48%. But if you look at high mosaic single chromosome, it is 32%. So there was a significant drop in the implantation potential as when you factor in mosaicism. Also, the probability of a spontaneous miscarriage also increased. So definitely mosaicism in the two factotum can have an impact. This begs the question, should we transfer mosaic embryos or not? We still have an ongoing pregnancy rate of 20 to 40% in mosaic embryos, and therefore it is always recommended that low mosaic embryos, that is in the light pink category, are definitely good viable options because 40% pregnancy rate is good enough. We should be transferring them. However, the high mosaic embryos tend to have a very high miscarriage rate, therefore they are not recommended at the moment. So unless you fix embryonic factors, you can't completely diagnose recurrent implantation failure. So the question was, does PGTA really impact the live birth rate, and does it really help patients with recurrent implantation failure? There are multitude of studies to support this finding. This was a very recent paper just published in February of this year, and this looked at multiple studies, and majority of the studies clearly showed that the implantation failure was always lower in the PGTA group versus the group without PGTA. So if you see this Gu et al. Paper of 2023, with the PGTA, the implantation was at 43%. That is the implantation failure rate. But without PGTA, the failure rate went up to 66%. This was concordant with the clinical pregnancy rate also. When PGTA was included, the clinical pregnancy rate was 49%. Without PGTA, 31%, 10% drop, close to almost. So this was a consistent phenomenon seen across all studies. Even if you look at results for every single embryo transfer, or you look at the cumulative rates of implantation failure, they're always better prognosis when PGTA has been incorporated. So what about the uterine and anatomical factors? We look at mainly, we have to exclude endometrial polyps, submucous fibroids, intrauterine adhesions, uterine septum, Mullerian anomalies, adenomyosis, hydrosalpinx, and thin and inadequate endometrium. So usually, as and when the thickness of the endometrium reduces, clearly there is a lower implantation potential. This is shown in multiple studies. So usually the endometrium should be minimum 6.5 to 7 mm to correlate with a good implantation potential. If your endometrium is not growing beyond this, there is a high probability of an implantation failure. Therefore, we might lose the precious euploid embryos that we have. So we need to focus on getting a good quality endometrium here. Now, when it comes to the receptivity, the main factor that handles the attachment of the embryo is the window of implantation. The endometrium is not always ready to accept an embryo. It specifically accepts the embryo only when the endometrium is receptive, which is known as the window of implantation. And this is evaluated by a test called endometrial receptivity array or assessment, or there are multitude of different versions from different companies, which basically look at the same factors. They look at the transcriptomic profile of the endometrium to evaluate the questions to say that is it receptive or not. You can also have progesterone insufficiency. So despite proper progesterone administration, if the endometrium is not reacting to the progesterone intake, definitely there could be some level of resistance, which then significantly impacts the implantation potential. So we need to make sure that there is proper luteal support and optimization in such cases. How do we evaluate all of these factors? So if you look at the endometrial receptivity, basically the window of receptivity is stipulated to be between day 19 to 21 in standard 29-day cycles. Now, if the window of implantation shifts to earlier phases, that means it could be an earlier window or it can be delayed. So you have a later window. And then there is also a subcategory of patients who have a very short window of implantation. That means usually the window of implantation lasts around 30 hours, but in some cases it can be as small as 6 hours also. So there are 3 ways to sample the endometrium, or rather even if you choose an endometrial transfer option, you have three options. You either do an HRT cycle where you have estrogen followed by progesterone intake and then the transfer. You can have a natural cycle which is monitored by the LH search, or you can have a modified natural cycle where we use HCG priming. How do we go about this? Usually we start the stimulation in the standard HRT cycle on day 2. We start estrogen priming, and when you see a triple layered endometrium, which is more than 6 mm, first thing you do is evaluate the progesterone levels. You need to make sure that the progesterone levels before you administer progesterone should be below 1 nanogram. What happens if it is higher? Ideally, it's preferable to cancel the cycle if it is higher, because again, if you add overdose of progesterone also, it will completely shift the endometrial response, and then you might face implantation failure. So when you start progesterone, always first evaluate the progesterone, serum progesterone levels, make sure they're below 1 nanogram, and many people skip this crucial step, and ignorance of this step leads to failure of endometrial receptivity test. That means we will generate the result for you as a company, but it may not really help your patient because the standard cycle will then not be reproducible. To start progesterone, and it is very, very important that on the first day of progesterone intake, you note down the timing of the progesterone intake. Many people skip and give tentative timings, and because the endometrial receptivity test is a timing-driven test, unless we put the correct time into the software, it will not give us the correct stipulated embryo transfer timeline also. So 2 main points we should always remember: never skip progesterone estimation before initiation of progesterone, and always make sure the date and time of progesterone is noted down properly. It is preferable that the timing of progesterone intake remains standard during all the days of progesterone administration. It's ideally preferred that maybe half an hour to 1 hour difference is all right, but preferably stick to the same timeline. And remember that the first day of progesterone is day 0 or P+0. Many people make the confusion that on first day they consider it is P1, P2, P3. It's not like that. We should always consider the first progesterone intake as P+0. This usually is done so that it coincides with the embryonic age also. So embryonic age is also calculated with day 0 because day 0 is the day of fertilization. Then you have day 1, and day 2, day 3, day 4, day 5. That is how we monitor embryo development. If you consider P+0, then you also have the same development. Considering first day is P+0, if you have P+0, P+1, 2, 3, if you have a day 3 embryo, it has to be transferred on P+3. P+3 essentially means after 4 doses of progesterone, right? Then you have P+5. Now, if you are doing an endometrial receptivity test, you should always do the biopsy on P+5. Even if you have a day 3 embryo, day 2 embryo, day 4 embryo transfer plan, doesn't matter. The biopsy is designed to evaluate, is the window of implantation open at 120 hours or not. Why is it so? Your blastocyst usually begins its implantation journey on day 5. That's when it is fully expanded, and that's when it intends to hatch. In the next 24 hours after your embryo transfer, the embryo should hatch and attach to the endometrium. You need some time to acclimatize to the in utero environment as well. Therefore, if you have a day 5 embryo, day 6 embryo, day 7 embryo, it is always transferred into a receptive endometrium. It is not transferred later. Because you have a day 6 embryo doesn't mean it's transferred on day 7. Why? Day 5 is when the endometrium is receptive for most of the cases. Now, if you look at IVF patients, 70% of the patients have their endometrium synced such that on day 5 it will be receptive. 30% of the patients will have a shifted window. For that purpose, this test is done. Now, you do a biopsy at 120 hours. We will look at the endometrial signature and say at 120 hours, is the endometrium receptive, pre-receptive, or post-receptive. Based on that signature, we will tell you when to transfer a day 5 embryo, day 6 embryo, day 7 embryo, or if you have a day 3 embryo also, we will tell you. So ideally, if your endometrium is receptive at P+120 hours, and you have a day 5, 6, 7 embryo, which is a blastocyst transfer, is always done at P+120 hours. If you have a day 3 embryo transfer planned, and the endometrium is receptive at P+120 hours, we will subtract 2 days and tell you transfer it 48 hours earlier. Now, If you go for a natural cycle, it is again important to measure the LH surge. You can give a home-based kit to the patient or let them measure the LH surge around the particular timeline. And if you miss the LH surge, then the entire calculation goes wrong. And this happens to us frequently. So many cases that we get in the natural cycle have not measured the LH surge, and we generate a result, but it is not of any use to your patient. So always make sure that an LH surge is measured properly over 3 days, 3 tests, so that you get to know exactly when was the LH surge. Based on that, you count LH plus this. Again, the day of LH surge is 0. So you count LH plus 1, 2, 3, 4, 5, 6, 7, and that's when you do the biopsy. If you're using a modified natural cycle, then you measure when you see the triple layered endometrium, you start administrating HCG. Again, HCG is the same way. First, HCG administration is 0, then you have 1, 2, 3, 4, 5, 6, 7. So it's usually LH plus 7, HCG plus 7, or P plus 5, which contributes to the day of the endometrial biopsy. So how do we do endometrial evaluation? So the biopsy is taken in a specialized tube with a buffer. This buffer is designed to stabilize mRNA. So what we're looking at is the transcriptomic signature, which is nothing but mRNA expression. mRNA expression is dynamic and it changes from every stage, from pre-receptive to post-receptive stages. There are signatures that are recorded by each company when we do our trials and verification of the test, clinical validation, etc. So based on that particular signature, the algorithm will identify and categorize the endometrium into pre-receptive, receptive, or post-receptive. Then it will utilize the time of progesterone intake and the date of the biopsy, and mapping to that timeline and the signature, the software will tell you the estimated embryo transfer timeline for blastocysts and day 3 embryos. In case you have a day 4 embryo or you do day 2 transfer, you can always talk to the company and they will give you a timeline, or you can just subtract from the window of implantation the age of the embryo and then plan it. Now, to evaluate the endometrial receptivity, there are 3 technologies available. You have RT-PCR, which is a gold standard technology for mRNA expression. RT-PCR looks at minimal number of molecules. So the RT-PCR based test looks at around 18 to 20 mRNA transcripts. The microarray has a little bit expanded coverage. So it looks at around 100, 120. The next generation sequencer is a high throughput machine. So this can factor in any number of genes, any number of mRNA transcripts. In NGS, we will look anywhere at between 250, 450, and even maybe 1,000 molecules. It depends on the company. So every company that uses NGS has their own custom designed panel. The limitation of this approach is that every company has their own validated protocols. So the challenge is it is very difficult to get the gene list because it is proprietary for each company. So therefore, your result between 2 companies may not always match. In most cases, it does. In about 80 to 90% of the cases, it will match. But in 10% of the cases, it may not match. So how long does the window of implantation stay open? So this was a beautiful study by this group from Spain. And they basically evaluated multiple timelines of the receptivity test. So they were using an RT-PCR based receptivity test. And they evaluated patients right from day 2.5 post-progesterone intake till day 8. What they found was the highest receptivity window ranged between 120 hours to 135 hours. So between day 5 to 5.5 to day 6. So between 120 to 135 to 140, you usually achieve your window of implantation. But there are always been cases of patients who have a longer window, which can last from 4 to 7 also. This is why most IVF patients do conceive despite our transfers, and a small shift here and there, it's completely okay. But what we see is, as and when the timeline shifts beyond day 5, the incidence of post-receptive. So the orange bars are the post-receptive one, the green is the receptive one, and the light orange are the pre-receptive ones. So as the day shifts later and later, you see that the incidence of post-receptive endometria keep increasing. Nonetheless, in a small subset of patients, that is almost about 9 to 10% of patients, they have post-receptive endometria on day 5 itself. So these patients have small windows of implantation, and here they will face a recurrent implantation failure. So we have had cases with, say, 6 euploid transfer failures, 7 euploid transfer failures, who fall under this post-receptive category, and immediately once the window is identified and they transfer, the immediate next cycle they have been able to conceive easily. How do we interpret results generated by companies? So this is an Anderson report for reference. So you have a representative image which says, yes, it is receptive. So this patient had their biopsy done at 123 hours. It was receptive. So usually the window is okay for ±2 or ±3 is how the window works. So the blastocyst transfer for day 5 or day 6 embryo is recommended at 123 ±2 hours. And your cleavage transfer is planned at 75 hours ±2 hours. In case you have an endometrium which is say pre-receptive in the same timeline, that means the window is behind. The transfer is pushed by another 24 hours approximately. So based on the software will give you a timeline. So we say in this case, the predicted timeline was 142 ±3 hours, and the cleavage transfer was 94 ±3 hours. In cases where the endometrium is post-receptive, the transfer might be recommended to be preponed to say 94 hours. But what we have observed in our past 5 years of doing this test is patients with post-receptive endometrium have one, fluctuating cycles, and second, smaller windows of implantation. So it is very difficult to accurately predict the receptive window. So what we have seen is when we do a repeat cycle, the endometrium shifts to a receptive phase. Okay. So it may be because of the repeated training of the endometrium in this process, but also we recommend that in the second cycle, we do 2 biopsies to be on the safer side at the predictive time of 94 hours as well as the 120 hours. So we get an idea of how the endometrium is changing within the same cycle, and then we pinpoint the exact endometrial transfer time. So does endometrial receptivity improve the outcomes with advanced patients or recurrent implantation patients? Yes, there are studies which are in favor of it and with not, but most good studies which are designed properly evaluate this phenomena with the integration of PGTA. So when you incorporate PGTA and endometrial receptivity analysis, you have a better pregnancy rate versus PGTA alone, and you also have better implantation rate, better live birth rates as well. And this is a significant difference. Other factors apart from receptivity and ploidy are other endometrial factors like chronic endometritis. Now, chronic endometritis basically triggers inflammation in the endometrium, and too much of inflammation anyway hampers implantation. One of the leading causes of implantation failure, and definitely if the patient is under suspicion of chronic endometritis, it's a simple endometrial biopsy test followed by CD138. The receptivity analysis does not factor in CD138 testing. It does not factor in chronic endometritis. It looks at different endometrial transcripts associated with implantation. So if there is a suspicion for a patient with chronic endometritis, please fix that problem first before going to the receptivity analysis. You need to treat endometritis, then evaluate the receptivity. If you do the receptivity now and then to do the endometritis panel at the same time and it's positive, then you have to disregard the endometrial receptivity test, treat the endometritis, and then repeat the endometrial receptivity test. You can also factor in endometrial microbiome because you need to have a lactobacillus abundant microbiota in the endometrium to facilitate implantation, because lactobacilli basically suppress pathogenic bacteria and they maintain the uterine milieu so that the implantation is successful. If there is a disturbance in both these factors, you can treat with probiotics and then do the receptivity analysis. Other factors to contribute. If you're looking only at PGTA and endometrial receptivity and still implantation is failing, the hormone factors are something you have to remember, because in cases of thyroid dysfunction, there is PCOS, obesity, insulin resistance, hyperprolactinemia. You definitely have a shift in the endocrine system itself, and that itself predisposes to implantation failure, right? So if these factors are not controlled for, all these expensive investigations are going to be redundant for the patient. So we need to make sure that even these factors are included in the evaluation of RIF patients. Another factor most people ignore is the resistance of the endometrium to progesterone. We frequently, the RIF cases that we get, we see that the endometrium is good, it's healthy, we have a trilaminar epithelium, we know that it's working, it's responding to progesterone, but in certain cases, especially in patients with subclinical endometriosis. This means that the endometriosis is undiagnosed because the lesions are very small and they may not be visible, but still these lesions induce progesterone resistance in the endometrium. This resistance impairs the decidualization of the endometrium and causes endometrial dysfunction, leading to implantation failure. The way to diagnose this is a simple endometrial biopsy with a marker test. It is done with immunohistochemistry for a marker called BCL6. It has been shown to efficiently diagnose subclinical endometriosis, and treatment with drugs like loperamide have shown significant improvement. This test was developed by a company in the US, and the test was called Receptiva DX. And they have done good amount of work. They've done hysteroscopy and certain drugs that they have tried, and they've published multiple articles which have shown significant improvement in implantation as well as pregnancy outcome in failed implantation patients. Another factor to consider is, of course, immunological and thrombophilia factors. Now, you cannot jump to these factors unless all other factors that are previously discussed have been ruled out. If the endometrium is receptive, the PGTA tested embryo is still failing, you have ruled out chronic endometritis, you have ruled out a disturbed microbiome, and you also have ruled out progesterone resistance. After these 5 factors have been ruled out, the next factors is, of course, the main factors, that is, I will come to it later. After that, you can evaluate the possibility of APS syndrome. Now, how does this impact implantation? Once your endometrium is receptive and the embryo is in place, it has to invade the endometrium, and after this happens, you have a series of vascularization events. Now, if there are microclots in those microcapillaries, it can completely cut off that region to blood supply, which again further can result in biochemical pregnancy loss, as well as can also cause the miscarriages. Therefore, treatment with heparin can be considered in APS positive patients once you have the pregnancy confirmation. And also the peripheral NK cells are now being evaluated, but right now there are no validated clinical thresholds, and large-scale RCTs are insufficient to say the immunological investigations are helping. But just to list out the variants that we look at NK cell activity in the endometrium, you look at peripheral cytokines, you can look at HLA typing of the couple, key typing in the mother, and the complete inherited thrombophilia panels. But all of these are not under the recommended investigation list under ESHRE. To rule out the male factor, mainly you need to look at the lifestyle, the hormonal factors. If your patient is diabetic and has a high HbA1c values, definitely the sperm DNA fragmentation index can be higher, and the methylation defects induced by diabetes also are high. And these defects, both DNA fragmentation with or without diabetes, methylation defects, and sperm aneuploidies can significantly impact the embryo's ability to implant. And therefore, if the patient has high levels of oxidative stress, high levels of sperm DNA fragmentation, it is significantly correlated to implantation failure and pregnancy loss. And it is important to reduce the DNA fragmentation levels with lifestyle modifications, which have shown significant improvement in IVF outcomes. And of course, we can use better sperm preparation techniques to improve the quality of embryos we get and to reduce the possibility of implantation failure. Now, how does implantation, DNA fragmentation affect implantation? So DNA fragmentation in the embryo from the sperm transfers to the embryo, accumulates over time. At the blastocyst stage, it manifests as apoptosis. So this DNA fragmentation is beyond the limited repair capacity of embryos. And when you have apoptosis, and if this is present in the toe ectoderm cells, it will directly impair the implantation and the transcriptomic signature of the embryo itself. And even in a receptive endometrium, in a euploid embryo, you will still face an issue because PGT-A cannot detect DNA fragmentation. In fact, there is no test in the world right now which can look at DNA fragmentation in the toe ectoderm cells. The ART laboratory and technical contributions include, of course, the transfer technique. Now, if you transfer the embryo in excessive volume of the transfer buffer, definitely there will be loss of the embryo and it will impact. And other sessions during the course will definitely address the transfer techniques by clinicians and embryologists. You have to look at the quality of the media to make sure that the embryo is not stressed in vitro. You can also look at the endometrial embryo synchrony, and all these factors can together contribute to RAF. So how does evidence-based management recommend the troubleshooting for RF? Basically, look at the transfer technique to see if there was any difficulty during transfer. Look at the thyroid dysfunction, metabolic syndrome, obesity, and glycemic control, which can impact implantation. We can evaluate receptivity. You can evaluate the endometrium with the chronic endometritis evaluation. Make sure the progesterone intake is optimized and customized for that particular patient based on their endometrial status for BCL6. And then, of course, the embryo selection criteria should incorporate PGTA testing. What is routinely not recommended is the immunological testing and sperm fish. Many sperm fish is not recommended because the aneuploidy in the sperm is not a guaranteed situation, because some sperm will be normal, some sperm will be aneuploid, and we do not know which sperm we pick for fertilization. And DFI basically is an overall value as well. So it is only by correlation you can understand, but we cannot guarantee the sperm we pick is aneuploid free or it is fragmentation free. You can do the biochemical thrombophilia, but inherited thrombophilia lack RCT backed up evidence. And then, of course, your assisted hatching has not been shown to significantly affect or improve IVF outcomes in RIF patients unless you have a thick zona. If you have a thick zona, assisted hatching can help, but in normal thickness of zona, when it is thinned enough in the blastocyst stage or hatching blastocysts are there, hatching is not recommended. Endometrial scratching is also failed to provide strong evidence in its favor. Caution against empirical treatments, for example, with steroids and IVIGs, large-scale studies have yet to establish positive impact of these conditions. So IVIG, prednisolone, GCSF, PRP are still under experimental use. Proper consent of patients should be taken before using these technology, these kind of medications for patients. But we should have to rule out the evidence-based parameters first before using these. So to conclude, the strongest actionable domains still remain PGTA, uterine pathologies, progesterone optimization and luteal support, chronic endometrial evaluation, as well as quality assurance in the laboratory side. So this is basically an overview of all the factors that impact. We should make sure that the nutritional status of the patients, their environmental exposures and psychological stress have to be taken into consideration. And things like tobacco use and obesity definitely have a strong impact on the implantation potential and the endometrial and embryo crosstalk. You have DNA fragmentation, and IMSI, PIXI are suggested in such cases. You need to rule out genetic abnormalities, and they are highly frequent now. And we have now set up a cutoff of 35 years. But what we experience in our country is that we are seeing a very high frequency of aneuploidies right from the age 30 itself. So our frequency of aneuploidies are much higher than the rest of the world probably, and which is something that we need to factor in. And most of the uteri that we see are having a dysbiotic microbiome, and it's we have to make sure that it is taken care of before we use embryos, especially in low risk patients. Thank you very much. I'm open to questions if anyone has any. Anyone has any other question, you can drop it in the message as well. Well, there is a separate session for immunomodulation. So it is beyond the scope of my discussion today. Today, we're mainly looking at the receptivity, but the Fertility Academy has a separate course on immunological investigations, and there are very experienced clinicians on that panel, and they will help you to understand immunological evaluation as well as immunomodulation. So you can check upon that factor there. Okay, so if there aren't any further questions, we can So there is a question on P+4+3. So if you're planning a day 3 transfer, you need to basically give 4 doses of progesterone. But if you are planning a endometrial receptivity test, you still you're planning a day 3 transfer, you still have to give 6 doses of progesterone, do the biopsy at 120 hours, evaluate the endometrial receptivity, and based on that timeline only you can plan a day 6, day 5, or a day 3. So once we identify the window of implantation, from that timeline, we will subtract your day 3 transfer. So the report usually incorporates information on day 3 transfer as well.
So Fiona, that was a very nice session, and I'm sure there are many questions for you.
There were a few.
Yeah. So where can we go wrong in this? I mean, because I've seen a lot of my friends who are IVF specialists, they have difficulty in interpreting the report. So I mean,
The
where
most
can things
common
go wrong? I mean, why should we prefer a particular lab's way of presenting, and where can we go wrong? I mean, in the technique as well as in the reporting.
So first of all, the biggest challenge we face is that in many cases, because a day 3 embryo transfer is planned, the endometrial receptivity test is all the biopsy for the endometrial receptivity test is set on day 3. That is the biggest mistake, because when we look at the window of implantation, you have to give the biopsy on the predicted window of implantation. So the standard window of implantation is P+120 hours. Doesn't matter what biopsy transfer you're planning, you should always give the biopsy at P+120 hours. Okay. Because if you give me a day 3 endometrial biopsy, without testing, I can tell you it's definitely going to be pre-receptive. I am trying to identify the window of implantation. Once I know the window of implantation, yes, at 120 hours, it is open or not, then I can calculate. If I come to know at 120 hours, it is pre-receptive, based on that, I can tell you when to do your day 3 transfer. That is one thing. The most common challenge is the timeline of progesterone intake is not recorded in most places, and most people forget or choose not to do the P4 evaluation on the day of progesterone intake. So if your P4 is more than 1 nanogram, you definitely are going to have a different result from your transfer cycle versus the testing cycle.
Absolutely.
It is not
Absolutely.
reproducible otherwise. Third, the natural cycle. Now, because of financial restrictions, people prefer the natural cycle for endometrial receptivity test. But what we really see is the natural cycle is highly prone to fluctuations. So if you have an RIF patient, the HRT is the best way to go. The natural cycle reliability becomes very poor. Fourth most common question, how frequently should I repeat the endometrial receptivity test? So usually endometrial receptivity tests are valid until at least 6 months, if not more. But after a year, there are possibilities of it shifting. So ideally, you should do that. The fifth most important thing, follow the same protocol that you've used for the receptivity testing and for the endometrial transfer. So if the patient goes to clinician A, she has a particular protocol, she does endometrial receptivity test, they do the transfer, it does not work, and they change the clinician. That clinician chooses another transfer protocol. The test is not reliable. It has to be repeated. So these things have to be kept in mind.
Okay, very valid points. And there's another question for you. What single base test is used for determining endometrial receptivity?
NGS, next generation sequencing based transcriptomic analysis, is the best test. You have multiple companies with different panels, and it is very difficult to assess who is good and who is bad. It's basically clinical expertise and experience and the validation protocol. So I'm not in a position to comment on which company is the best, because I will be biased. It will be a biased answer, so I cannot do that. So I think it's up to you guys to see how the company represents their clinical data to you, and what is the ease of convenience, the financials of it all, and then you can plan to do.
If you're in what percentage of samples do you find that the window has shifted? I mean, suppose you're receiving 100 samples in a year, or in 6 months or 3 months. So in how many percentage of people do you find that the window is shifted, and it is actually the correction of timing might result in implantation? I mean,
roughly 25 to 33% patients have a fluctuation.
that's a very high.
Approximately 70% of the patients remain receptive. This is seen in multiple other studies also. The global consensus also is the same. We validated our study with the European partner, so even they had similar results. So, and in the non-receptive category, you will have, say, pre-receptive is majority, say 15
Mhm.
to 18% will be pre-receptive, 8 to 10% is post-receptive.
When you say pre-receptive, you have to transfer early,
If it's pre-receptive, you have to transfer late, sir.
transfer
Because the
late.
endometrium is
Um,
behind, it is not caught up to the window. So you have to
Okay.
transfer 1 day late.
And all the timings are in context of day 5 transfer. I mean,
Always, the report always comes with the context of day 5, and you
day
have a
5.
subcat clause for day 3 transfer also. So if you're planning a day 4, you need to subtract the timeline given by 24 hours from the window of implantation.
And generally, how long is the implantation window? I mean, 48 hours. I mean, how many home
So
in your
ideally, it is around 30 hours is what literature says. But there was a study which was done with the Spanish group, and they looked. Some people can have a window open as early as 2.5, and it can go stay open until day 8 also. So it is pretty broad, and it is different in different individuals.
Okay, there are some questions in the chat box. How soon can we plan for a FET after doing endometrial biopsy to determine implantation window? So after
Well,
biopsy, how soon can you plan FET? Next cycle, 2 cycles?
next cycle only. Next cycle
Next
only. It
cycle only.
cannot be done on the same day because the result is going to take time. The companies like in India is the fastest reporting timeline is 2 weeks, and I don't think anywhere else in the world they give you earlier reports for this particular test. So it's always the next cycle, and you cannot do endometrial receptivity in the IVF cycle. That is not recommended.
Okay, another question for you. Does BCL2 detection in the endometrium change the management?
Yes, it does. So if your endometrium is positive for BCL6, it means that there is progesterone resistance in the endometrium. So you need to treat the patient with certain drugs. I can share the article in the group actually, and those drugs have been shown to have an improved outcome in with respect to implantation and pregnancy sustenance as well. That
Okay,
is my question.
better progesterone for FET oral or vaginal or subcutaneous or intramuscular. So I think we need to. Are you going to answer this? Because
I
I
think
think
it's a
Dr.
clinical
Monica,
clinicians can
it's a
tell you
clinical
better.
question, and we recently had a lecture on luteal phase support, the last session,
Hmm.
and it's available on YouTube. And we can take the question with Dr. Monica. She'll be the right person to answer. But I think nowadays she is giving vaginal progesterone,
Yes,
as far
yes.
as I
Many
understand.
clinicians are using vaginal progesterone, they've told us.
Yeah.
For
Yeah.
us, it doesn't matter. As a diagnostic company, it doesn't matter how you administer progesterone. What matters is you repeat the similar protocol. It should be identical for the transfer.
Fiona, Dr. Rupali is saying that please share articles for management of cases with positive NK uterine cells as well, BCL2 as well as NK uterine cells.
Yeah, I can do that, ma'am. And we also have a course on immunology workup
Yeah.
and the transfer treatment run by clinicians. So you can always look that up with the Fertility Academy program.
Yeah. Can you explain the distance the embryo should be transferred and the inner catheter tip placement? So generally we transfer around 1 to 1.5 centimeter proximal to the fundus, uterine fundus. What level of P4 should be maintained during FET cycles? Again, a clinical question, but it should be less than 1 nanogram if
One
for to
nanogram. Before
consider the
you start
transfer. Yeah.
progesterone intake, it should be less than 1 nanogram.
Yeah.
If it's more than 1 nanogram, you need to cancel that cycle. You should not be giving the sample in that cycle. It's not reproducible otherwise.
So I don't see any more questions. Thank you, Fiona, for that wonderful session. Very
Thank you,
interesting.
sir.
And uh, so the session will be uploaded on the YouTube channel as well as on the app, but it will take a couple of days for us to do that. So kindly bear with us. Thank you so much for being there attending. And today is the last day for embryo transfer course registration, just to remind you in the end. So please make use of the time. Thank you.
Thank you.
Thank you. So Fiona, you can end the meeting. Yeah.
Yeah, sure, sir. Thank
Bye.
you.
Bye. Take
Bye.
care. Have a great night. Yeah.
Yeah.